Welcome everyone to the American Academy of Pediatrics. My name is Shireen Khan and I'm your host for today's show. We have a really exciting program for you where we're going to take you all around the world into immediate kangaroo mother care. Now, this is a strategy that has reduced infant mortality by 25%, and we're going to take you into India, Ghana, Nigeria, and all around the world to show you its efficacy. So I want to get started with introducing you to Dr. Jana Patterson. She is our Senior Vice President at the American Academy of Pediatrics. Now, I'm going to tell you a little bit about Jana, and then I'm going to let Jana tell us about how she has kicked off this work in the origin story for iKMC. So Dr. Jana Patterson oversees global programs and leads multiple equity and mentorship initiatives. Previously, she was a senior program officer at the Bill and Melinda Gates Foundation, where she managed grants on maternal and newborn health, ranging from the prevention and treatment of sepsis to care of the preterm infant, including, of course, kangaroo mother care. She's been a practicing neonatologist and researcher on faculty at the University of Washington and spent several years working in Tanzania at the Tanzania Public Health Association. So Jana, please kick us off and tell us a little bit about how you got involved in immediate kangaroo mother care.
Thanks so much, Shireen, and thanks for that kind introduction. Gosh, this has been such a journey. You know, KMC has been around for such a long time, back since 1979, and Drs. Ray and Martinez really coined that term, kangaroo mother care, and got it started in Bogota, Colombia. But for decades, you know, it just didn't get a lot of uptake. You know, it was only like 5% coverage in the babies who really needed this method of skin-to-skin care and exclusive breastfeeding. And so when I joined the Gates Foundation in 2014, people were talking a lot about this. You know, why isn't KMC getting good coverage? And I remember having this conversation with a prominent Indian neonatologist. He said, Jana, you know, if you don't do KMC until babies are stable, half of the babies have already died because that doesn't happen until they're several days old, even a week old. And I thought, yeah, that's right. And around the same time, I started getting outreach from Dr. Niels Bergman, who is a Swedish man that has been living and working in South Africa for many years and is a really ardent fan of KMC. And he kept after me and he said, I need to meet with you and explain to you in person the power of KMC. So I said, okay, I'm flying through the Durban airport. I'm there from 7 a.m. to 7:30 a.m. on a Sunday morning. If you can meet me, we'll talk. And I thought, okay, that might kind of scare him off. But no, he was determined. He came, 7 a.m. Durban airport on a Sunday morning, and he opens his laptop and has over 100 slides all about the science and the neurobiology of KMC, but also the science of spider bites. That's what he did his PhD on. And I thought, what in the world is this? But he walked me through it. He walked me through how some of the neurochemicals are similar that are released after a spider bite and when a mother is in close contact with her newborn. And we said, okay, this makes sense because this helps to stabilize a baby. Having that neurobiology between the mom and the baby and the release of oxytocin and all those great things that happen when a baby is on mom's chest, we need to figure out a way to use this neurobiology to stabilize babies. And so we started looking at many different sites around the world and where we might actually test this, because the WHO guidelines said KMC is only for stable babies. And we said, okay, if we really want to convince other nurses and pediatricians and neonatologists that KMC can be used to stabilize babies, we're going to have to prove it with some data, right? So that's when we found sites where we could do a trial and test it in unstable babies and see if we could get better results. And it really kind of went from there.
Wow. Well, that discovery alongside spider bites and how bodies respond is so fascinating. And we do have so many experts here today with us that are going to give us even more insight into iKMC and how it actually works on the ground. So before I introduce you to our guests, though, I want to give you a few housekeeping announcements for our audience that's joining us all around the world. So the first is that we do have live interpretation in multiple different languages. We have Spanish, Portuguese, and French. So for our audience, if you could click down to the bottom of your Zoom window on the globe, then you'll be able to select the language that you want to listen in. Even if it's English, do select that so you have the cleanest audio. So English, French, Portuguese, and Spanish are options for live translation. And as for chatting for our audience all around the world, please do send in your questions. So use the Q&A feature. Let us know where you're writing in from. That'll help me throw it to the guest that it's the best question for. And I want to introduce you to our guests now. So joining us from Lagos, Nigeria is Professor Adejuyigbe. She's a professor of pediatrics and child health at the Obafemi Awolowo University in Nigeria and a consultant neonatologist. She's the VP of the African Society of Pediatric Infectious Diseases and has served as a consultant to the Nigerian Ministry of Health on Childhood Diseases. On the global level, she serves on committees within the World Health Organization and is a principal investigator in a number of studies across the African continent on neonatal sepsis, nutrition in early life, and iKMC neurodevelopment. So Professor Ebun, thank you so much for joining us. Next, we're going to go all the way to India, where we have Dr. Harish Chellani. He's a pediatrician and professor of pediatrics at the Vardhman Mahavir Medical College. He has led the newborn unit within pediatrics at Safdarjung Hospital in New Delhi for decades and has consulted on scaling up facility-based newborn care. In India, he's served the government for over 35 years in committees and task forces and worked on research projects funded by the WHO and the Indian Council of Medical Research. Dr. Chellani has authored more than 100 research articles and chapters. Dr. Chellani, thank you so much for joining us. Next, we're going to go to Ghana, where we have Dr. Naana Brobby. She's a pediatrician neonatologist at the Komfo Anokye Teaching Hospital in Kumasi, Ghana. She's a lecturer at the Kwame Nkrumah University of Science and Technology, and she's worked exclusively with newborns for 12 years, focusing on prematurity, neonatal jaundice, infection prevention, and control. Naana was the co-chair for organizing the committee responsible for the first ever perinatal conference in Ghana this year. So Naana, welcome to you and thank you so much for joining us. And our final expert is Dr. Suman Rao. She's a pediatric doctor and professor of neonatology at the St. John's Medical College in Bangalore, India. She serves as a consultant at the World Health Organization and serves as the treasurer of the IAP neonatology chapter. She is particularly passionate about quality improvement, infection control, and perinatology. And along with our other panelists in their united passion for iKMC, she has published over 100 peer-reviewed papers in 30 book chapters. So we have an amazing lineup for today. Do drop in your questions to our Q&A for later in the program. And I want to direct you all to a video that's going to show us immediate kangaroo mother care, how it is put to use and how we can see it on the ground. So have a look at this video.
The iKMC, the babies are put right on the mother's chest, skin to skin on the mother's chest or on the surrogate's chest from labor ward or from the labor ward theater.
Immediate kangaroo mother care is like being more daring and trying to initiate this care as soon as possible after birth.
We are changing the norm actually, making a case that mother has to be with the baby 24/7.
We are able to involve them in the care and make it a family-centered care. So it was easier for us and even more better for these babies. And we have seen the results.
It's an exciting study. It's never been done before, and we know there's very huge mortality in this patient group. Current practice is that the baby is admitted and they're receiving the acute care, and the mothers come in every 2 or 3 hours or so to just hold their babies and then help feed them.
70 to 80% need only assisted feeding and prevention from hypothermia. And for this purpose, they are admitted and separated from their mothers. The mothers are only a visitor.
There are a lot of advantages for KMC, because the baby feels comfortable and secure, and it also promotes bonding.
The idea about iKMC is it possible to provide these two cares? Firstly, give them the medical care which they need, and secondly, in addition to that, can we also give them kangaroo mother care, which has also benefits.
When you have such a high reduction in the mortality, that means if I provide this intervention to babies between 1 to 1.8 kg, we are saving 150,000 babies globally every year. So if I provide immediate kangaroo mother care to 27 babies, then I would be saving one life.
The evidence speaks for itself. The iKMC has shown clear benefits in terms of survival, in terms of infections for the newborn, and we now know that all levels of interventions can be performed with the babies right there on the mother's chest.
In the past, mothers have to go and stay outside our ward. But because of the MDQ, the mothers now stay with their babies, and they can care for their babies, and they are satisfied.
If your baby is inside the incubator, it's only nurse and the doctor that can know much about them. But if they are with you, you know everything about them. You can play with them. You will know what is happening.
I felt it was better for the child to be with me, the mother, rather than alone without adequate care and warmth. In my view, kangaroo care should start immediately after delivery of a baby. It helps the baby survive.
The ratio of nurses to the babies is also quite large. So in that case, mothers being there and taking care of their babies is an advantage for both the mothers and the health workers.
When the baby is in the NICU without mother, 2 nurses or 3 nurses tackles 20 or 30 babies. So chance of cross infection are more. Here, one mother, one baby.
The mother is not a mere visitor. She is the care provider. So she is changing the diaper and giving the feeds. So the rates of sepsis are less.
There was 18% reduction in the clinical sepsis or infection rates.
It also avoids hypothermia that comes when the baby maybe is in cold, because the mother's warmth is the very vital warmth.
Even the mothers were able to signal to us if there is any problem. So babies are not left alone when we are caring for them. So it was easy for us to know when there is problem and then to be able to intervene promptly.
If the baby is going into apneic attack, the mom can easily check the baby. If the baby is not breathing properly, the mom can easily check the baby, and they can easily feed the baby like frequently.
It also increases the rate of breastfeeding, as was shown in this study. So if babies can breastfeed, we know what benefits can have from that.
When they feed the babies, sometimes they vomit, and when they are on KMC, the mothers, they identify that quickly. While the baby on the cot, they can do that and nobody can notice, and the baby can die.
postnatal care is to be provided inside. So our obstetricians, they have to come inside the newborn units, and your neonatal nurses who used to provide care to the babies only, now they will be providing care to the postnatal mothers also.
At first, when I was told about iKMC, I thought it's not possible. By then, I felt like most of the babies, they cannot be stable enough to be put skin-to-skin contact with their mothers.
We were initially skeptical about carrying babies on the chest, we were not used to it, and very small babies for that matter.
We didn't have the wherewithal, we didn't have the skill, we didn't know how we are going to put it in place. But fortunately for us, lo and behold, we had good results. So it was easy for us to accept it.
My opinion has changed. Because of the experience, I feel they can get every care and nothing is compromising that.
At first, I thought the nurses were joking. But now, I see that it was helpful. My baby was born very early. Kangaroo care helped it to survive.
I was like, how come? She's not an animal, how can she put? But when I saw some people doing it, I was glad. It's like creating a bond between mother and their baby. I will encourage all men outside there that they should encourage this development by putting their baby on their chest, because the sweetest sound a baby can hear is the heartbeat of the father.
It's going to have a huge impact in terms of how we begin to start to look at both the mother and the baby again as one unit of care.
I think that is enough evidence for any government, particularly a government who wants to attain the neonatal goal for the sustainable development goal, which is to reduce newborn death. So I guess any government will want to see that this is a cost-effective intervention.
The mothers also have trust because they feel iKMC has saved their babies. So I feel so great, especially when I'm looking at the outcomes. I feel very happy.
The line that hits me from that video is the father saying the sweetest sound a baby can hear is the sound of his father's heartbeat. And I think that really gets to the core of immediate kangaroo mother care being a community approach to care for preterm babies. Let's go over to Harish. Why don't you tell us what was your aha moment with iKMC that you really realized the potency of this strategy?
While we started the study and not even the results were available, but what we could observe was the satisfaction and happiness onto the mother and the family they were having. That made us confident that we are on the right track. But of course, later on, when the results came, that showed even the significant improvement in the survival. So that was the moment with whole journey we were observing.
And I want to hear that from all of the guests. So Naana, let's go back to you. What was your aha moment, particularly if there was one story that comes to mind? Of course, you've worked with so many families, but what was the one story where you really realized like iKMC is incredibly effective?
Can you hear me now?
Yes, I can hear you beautifully. Go ahead.
Okay, great, thanks. So I was saying that fortunately, Ghana was part of the iKMC trial, so we had the opportunity to be part of it. Initially, so we had a couple of babies who ended up in the control group, but there was one that ended up in the intervention group. I remember it so clearly. The baby was about 1.02 or 1.05 kilos, and the mother couldn't come, and there was no relative around. Then I think about 90 minutes after birth, the father came around. So then we figured, hey, why don't we use the father? Okay, he initially was very reluctant. Now, this was a 1 kilo baby that we had put on the bubble CPAP. Baby was very agitated, kept on desaturating. And I recall that my nurses were reluctant to put the baby in skin to skin with the father. First of all, the father wasn't very agreeable to the idea. And the baby had been having some desaturation moments, but we decided to give it a try. So with the CPAP machine on, baby on IV fluids, we're given the caffeine and everything. We placed this agitated baby in skin to skin with the father. And within a few minutes, baby simply calmed down, barely had any desaturations, stayed there for about an hour or two. And then, of course, the father said he had to go out and look for money. So he had to leave. But at that particular time, I could tell the difference that the skin-to-skin contact, just the skin-to-skin contact made with the baby. It sort of calmed down the baby. The vitals seemed normal. And I figured, hey, maybe this could make a huge difference, you know, because this was one of the smallest babies, 1.0 something kilos. So that was when my confidence in the iKMC started going up. It's a story that stuck with me.
And for our American audience listening, 1.02 kilograms is 2.2 pounds in Naana's story. So thank you so much for that, Naana. Ebun, I would like to go to you next. What was your aha moment of working on iKMC?
Yeah, there were so many aha moments because, like has been said over and over again, we had not done it before. Seeing an unstable baby on the chest of a mother and being cared for on that chest was really, out of the blues. So when we saw that we could do this, give CPAP, take blood samples, do everything on the baby, on the mother's chest, I mean, that was a big one. So I think there were quite a lot of them, but that's one simple one I can remember.
Thank you. And last but not least, Suman, tell us, what was your aha moment of working on immediate kangaroo mother care?
For me, immediate KMC was nothing new when I went into the study as a sort of coordinator for WHO, because in St. John's, we had already done a feasibility trial and our nurses were convinced, and we were putting babies on CPAP and mechanical ventilation. But one thing which really touched me, I remember this when I was at a site. There was a baby who was just maybe, I think, 1.2, born to a mother with severe PIH. She hadn't come in for 2 days because she was very sick and in the ICU, but she came on day 3. And the surrogate, who was her mother, handed over the baby and the nurse helped her. And then she started crying. And of course, this baby was sick with CPAP. And I was concerned, but was she concerned that the baby is too sick? And I said, shall I, help you and maybe give it to you a little later? But she said, no, I want to hold on. And her thing was, she really didn't think that her baby would survive because she had so much of problems. And for her to really hold the baby, even though the baby was sick, really made her in tears. And she was one of the mothers who were doing iKMC for so long. If you know, in the trial, the duration of iKMC has been huge, 17 hours per day in the trial, even in the NICU. And that is, I think, the big reason why iKMC has shown such a change in mortality. So for me, it is just sort of a confirmation that this is what it is supposed to be. That is the main aha moment. And we see it every day, day in and day out when we do KMC.
Wow. And in terms of, Suman, in terms of the mother being able to provide that comfort and that stability for the baby, even in her own weakness, can you speak on that a little bit more? That I'm sure people have questions about exactly in the story you just told of, if the mother is facing different health challenges herself, then there might be a hesitancy of giving her the baby right away. In the story you told, it wasn't until day 3 that contact had occurred. So tell us a little bit more about the mother's preparedness, even despite the health challenges she might be facing.
Yeah, I think there it is very important for this intervention to be both an obstetric and a neonatal intervention. And that is what will help us in providing iKMC, because the mother is sick, she needs her care, and it's very important for the entire team to be very confident that they can do the best for both the mother and the baby. Till now, all of us are used to working in silos. Yes, I can do something for the baby, and the obstetrician says, yes, I can do a lot of things for the mother, but to match those things and do it in the same place, that is in the MN ICU, I think bringing these two departments together to work continuously together, and the confidence that we can do the best for the mother. Even we know this mother will require monitoring, but we are able to do it in the MN ICU. That's very, very important to support both the mother and the baby.
Absolutely. And Harish, I want to bring you in here. So the MNICU, walk us through what the MNICU is and how this is a monumental shift from keeping babies in the NICU and mothers in their rooms separately.
Yeah, Sherin, actually, conventionally we see globally, we separate the babies. The moment the umbilical cord is cut and the baby is sick, the baby is kept in the NICU, and the mother is either discharged or mother stays in the postnatal ward. And mother comes only intermittently to see the baby or express the milk and give that. So what we have been seeing actually all along, that it is a stress onto the mother, what is happening inside actually. So now this new unit which was started for the study purpose, which has all the facilities of level 2 newborn care unit. Only critically sick babies, those who are on ventilators and or the mothers who are critically sick, only they were kept in the high dependency unit areas. Otherwise, this unit has got the mother's bed, the baby's, in the radiant warmer or the incubator, the what we call the level 2 facilities, that oxygenation, intravenous fluid administration, or CPAP unit. So where exactly, if we see 85 to 90% of our babies are being cared, now there is additional bed for the mom. So this is the new infrastructure was developed, and that is where, initially, if suppose mother is unable to come because of the obstetric reason or for observation or so in our culture, it was easy to get the surrogate, and the most of the time, in fact, 70-80% of the time, we had the surrogate available, and they provided till the mom is ready. Or in between the time when suppose mother has to go for the washroom or other thing, the surrogate is available to provide the kangaroo mother care. So it is almost a zero separation, of the baby and the mom or the surrogate. So that's the infrastructure which we got developed actually for this, which is what Suman was saying, mother newborn care unit. Over.
And in terms of the surrogate serving as that body warmth, the care provider, how is that different than if simply, a nurse or someone else is picking up the baby and providing that instead of a family or community member?
Yeah. So kangaroo mother care, we say it is providing the thermal care, the principle of transmission of adult heat to the baby. So that's number one. But second, also it's support to the exclusive breast milk feeding. So and this is what we have seen, that in kangaroo mother care, when the mom is providing, so it's not only thermal care, it is the support to breast milk feeding. And another biggest advantage is that the same microbiota, same microbiome, the baby was exposed to the same bugs. Now baby is exposed to the same, in contrast to the conventional unit where the baby is exposed to the resistant bugs. So one of the reasons of the reduction in the mortality was that, of course, the early availability of the milk, thermal care, and also the reduction in the sepsis. So these are the advantages with the mother. But yes, if the time when the period when the mother is not available, That time, any adult person can provide the thermal care, and later on, the rest of the for the provision of the breast milk, the mother can chip in later.
Shireen, I would just like to add, like you asked for a comparison between the nurse and the family. I don't think there's any comparison.
Okay.
Nurse provides medical care. The family provides a holistic care. And KMC is not only about, taking care of temperature or infection. It's also about you're providing the best form of developmentally supportive care that you can for the baby. And therefore, for me, there's no comparison at all. And we need to provide this kind of care because you want the baby to grow in the family. And it's I would say this is the epitome of family-centered care, where you keep the baby and then they're all working together. And the nurse is there, but I would say a peripheral. The family is the mother, the core, and we always need to remember that as far as newborn care is concerned.
I also want to. Yeah, I want to also add my own voice to that, because you see, there's a difference between the family and healthcare providers. There is an intimacy that comes in, because this is my family. This is somebody that I know, somebody that has, that I think there's a bond between us than a health worker who just does this work for everybody, So I think there's a difference when it's a family than when it's friends, because they said they have a bond, that's why they are friends. But when it's now a health worker, it's a health worker. The health worker can just be there. And so I think there's a difference between a family and a health worker.
Thank you, Ebun. And Harish, I heard you were trying to jump in there too. Go ahead.
That, in continuation to what Dr. Suman was saying, it's the lot of work in the conventional newborn care unit, which the nursing colleague is doing it, that can be done by the mom herself, like changing the diaper and the expression of the milk, feeding the baby, so by the cup and spoon. So those type of the work can be done by the mother, and this will be a concept of task shifting. So now the nursing person can, move on to the monitoring of the baby and doing the other skills which she is, trained to provide. The rest of the jobs can be done by the mom. So that's what Dr. Suman was saying. It's a developmentally supportive care, less infection, involvement of the mother, handling of the mother right from the beginning. So that was.
Thank you. That's a really important point of shifting the tasks and shifting the weight of who is doing what and who can provide what care and what capacity. So let me switch over to Ebun. Ebun, can you give us a story in the field? We know that Nigeria struggles with infant mortality, one of the highest rates in the world after India. So tell us about providing iKMC in the field in these different capacities and what you have faced.
Yeah, thank you so much for that question. We know that Nigeria is the second leading contributor of neonatal deaths to the world after India. And we also know that even infant mortality, most of them are due to neonatal mortality. So when we did this study, it was a lot of problems in the sense that though we have a high rate of mothers who register in formal health facilities for antenatal care, delivery rate was also was low in the health facilities. Most of the babies were delivered outside the formal health facilities. So we had to look for a way of mobilizing the delivery of the small, vulnerable babies into our health facilities so that we can do the study. That was a big, that was a challenge, but we were able to overcome that, okay? And not just that, the other area is also the belief of people, once we are used to a particular habit, to change it is difficult. Changing it, now, babies normally are rushed to the incubators when they are very small. Now you are saying put them on somebody's chest. That's a real change from what we know. And okay, so we had to reorientate ourselves. We had to train people on how to even put babies on the chest. And we had to also know that it can work because it has worked somewhere before. And then we saw it work. So there were quite a lot of challenges when we were able to surmount it. And I will also say that for all the sites, many of the sites were not up to the standard that WHO will accept for minimal care for the vulnerable or the small and sick newborn. And that has to be, all the sites have to be brought to that level by provision of the respiratory supports for training on feeding and also on antibiotic care. So that was that was across all sites. Thank you.
Thank you, Ebun.
Again, if I may just add to what Ebun said,
of course.
The minimum care package was something that the WHO sort of insisted is there in all the sites, that this should be the minimum standards we have. And in fact, I think because of this, the initial estimates of mortality that we had, really, the mortality crashed. In some sites, it was half of what it was. Ghana had such a wonderful reduction in mortality, not because of just iKMC, but because of the minimum care package. And despite that reduction in mortality, iKMC study could show a 25% difference. For me, that's a big thing, because many times you see in studies, you say that, it did not show a difference because the overall reduction in mortality. But here, despite that, and that actually shows how powerful iKMC is as a tool to reduce mortality. And for India, Nigeria, many LMIC countries which is battling with it to meet the single-digit NMR goals, iKMC is a very, very important tool to adopt.
Thank you, Suman. And Naana, let's go back to you, since Suman just mentioned how we've seen incredible progress in Ghana. So tell us a story from the field on how iKMC is put into practice. As Ebun had mentioned, that we have a lot of delivery spaces that aren't formal hospitals. There's a lot of adaptation that has to come to get to this point of being ready. So tell us about what it's like in Ghana.
Sure, and thanks. So you can hear me now, right?
Yes, yes.
Okay, all right. So I must say that the bulk of the iKMC experience comes from during the study. The bulk of it will come from there. Initially, we had some challenges. First of all, practicing iKMC means that you have to collaborate strongly with the obstetricians, and then the midwives. And then there had to be infrastructural changes as well, because now we are moving beds into the NICU literally for the mothers. So it was a new thing for our nursing staff, for even the pediatricians working in the newborn units, as well as the obstetricians. Because here's a situation where as soon as the mother delivers, she has to be moved to the newborn unit. And initially there was a bit of resistance, because that means that when the obstetricians are looking for their mothers to review them after the surgery, especially cesarean, after the delivery, especially a cesarean section, they would have to come all the way to the newborn unit. And it was like we're adding to their work. And then there was an issue of, follow-up care in the neonatal units. Now you have nurses who are used to catering to babies now having to cater to the mothers there. So one example comes to mind. We had this mother, she was in her early 20s, and for some reason she developed early liver failure. She had this big abdomen, the big spleen and liver. She had pedal edema, and she was very reluctant to practice the skin-to-skin contact, which was understandable because she was feeling ill at the time. And I remember the obstetricians kept on arguing with my consultants that, why don't you just move this woman to our unit? It would be easier for us all, because here's a situation where we had our neonatal nurses seeing to this mother. I mean, the obstetrician, the team would come in the morning, leave instructions, do this, but then during the day, the mother is complaining that she's feeling dizzy. The complaint would come to us. And so you'd have to sort it out before walking all the way to the maternity unit to try and get the team on duty. But in the end, we all came together as a team. And over time, even though the mother was not feeling too well, we kept on placing the baby in skin-to-skin mode. And we noticed a change in her attitude. It was almost like she started having a sense of purpose for her baby. So as the days were going by, she became more hopeful. She became more involved in the care of the baby. Even when you're going to review her and you take the baby out, then she'll tell you, you know what, I'm okay, just keep the baby there. Okay, so until both mother and baby were discharged, they were in our unit. And it was a bit, initially, of course, we're all anxious because we're thinking to ourselves, God forbid, if something should happen to this mother, the obstetricians will go like, aha, we warned you, you know? But in the end, we collaborated, and it's always been a success story for us. So subsequently, when we request that the mothers come, for mothers who are stable or fairly stable, they didn't have any problem with that, because if we've managed to see to this ill mother with their help, then for those who are stable, it shouldn't be a problem. And afterwards, it was more of a smooth sailing. So when it comes to practicing of the iKMC in our unit, of course, there were challenges. One example was, of course, I've mentioned the space, but there was also the issue of surrogates. I mean, it's not every time that the mother can come, especially if it's a cesarean section. Even if she does appear early enough, she complains that she's in a bit of pain. So then a surrogate would have to take over for the immediate skin to skin. In Ghana, there's big, let me say in our hospital, let me put it that way, there's big reliance on relatives for following up with blood, going to take care of the bills, going to the pharmacy to collect drugs. So the same relative that you are hoping would come and start the immediate kangaroo mother care or immediate skin-to-skin contact is the same person running around looking for drugs for the mother. And then the same person will tell you that, you know what, I have to go out there and look for money because I'll be the one to pay the mother's bills. So it can be difficult. If you're not committed, there's the high tendency to give up. So the whole thing revolves around education, not only for the relatives or the surrogates or the mother, but the healthcare professional as well. Because if the healthcare professional does not buy into the whole concept, then it's a lost cause. You easily give up.
Mm-hmm. And Naana, I want to bring in one of our audience questions because Emmanuel Adams is asking something that you just referenced. So you said that, you know, the family members that are providing support, you know, they might be expected to provide skin to skin, but at the same time, they have to run and pick up medication or something else. So Emmanuel asks, what about bringing infection from outside into the NICU? Is that a concern?
Yeah. Okay, so that's definitely a concern, but we, for the past few years, we've been big on infection prevention and control. The concept of hand hygiene. We've been very, very big on hand hygiene. We try to get, we get a bottle of hand sanitizer for every incubator, every bed and all that. And as soon as you enter the unit, one of the first things we ask you to do is wash your hands. So we counsel the mothers as soon as they enter the unit. And it's gotten to a point where you can actually see a mother bring in the baby's father, and then the mother will instruct the husband that if you don't wash your hands, they will not allow you to touch the baby. Mm-hmm. Okay, so we try, it's an ongoing process. It's definitely been very difficult, but I think that IPC is the key here. Okay, sometimes you even need to worry more about the healthcare workers in the units than those coming from outside. Okay, absolutely. So it's an ongoing process, it's a team effort. Definitely, you cannot 100% say that they will not bring in an infection, but we know that hand hygiene reduces infections by about 40 to 45%. Okay, so that's something that we need to take up and practice alongside the iKMC.
Mm-hmm. Harish, go ahead. I heard you popping in.
Yeah. So Sherin, I think when we also started this unit, the same concern was not only from the healthcare professionals, but also the program manager, medical superintendents and all. But as it has been mentioned that the mothers, they follow the same culture of hand hygiene as whenever she enters the NICU. So that initial was that practice. Second important thing is, which I was saying, mother would be the best nurse. Whereas when we see in the conventional newborn units, as the 2 or 3 nurses managing 20 babies, there would be definitely breach in the asepsis. So that part would be, the cross-infection chance would be higher in the NICUs. Secondly, it has been seen in the literature, which we also found out in our own study, the infection rate was less rather, and also the sepsis-related mortality was also less. And the possibility of the, as I was mentioning earlier, that early access to the breast milk, and secondly, the same microbiota. So same microbiome that will reduce the infection in the baby. So it is a common belief that the adults would bring the infection, but it has been proved otherwise. So there will not be any concern now that mother would pass on the infection. Rather, as Naana was mentioning, the mothers are more careful about their babies, and they were following the hand hygiene practices much more, even the healthcare professional. Once I know the instance, one of our resident doctor was touching the baby without using the sanitizer. So she only gave her the sanitizer, that use the sanitizer before you touch my baby. So that kind of, the awareness comes in. And the another thing which we learned, that the mother who stays in the newborn unit for a longer days, she becomes the advocate for the other newcomer mothers. Actually, they tell them how the routine of this mother newborn care.
Suman, go ahead.
Yeah, so I mean, this is such a common belief that we all need to dissuade about, sometimes I have done this as a PI in the scale-up study also. We find that health workers probably are the biggest barriers to family-centered care and kangaroo mother care. The big concern is infection. We need to remember that we, as health personnel, harbor the bad bugs. The family harbors the good bugs. And it's important that the baby gets a good bug so that we don't, even if the baby is exposed to our bad bugs, the good bugs are fighting. So this is something that is such a common concern, but this is not only not going to increase infection, but it's a very good tool to reduce infection. So we need to really think of family-centered care, kangaroo mother care as tools to reduce infection, because infection-related mortality is quite high everywhere, and this would be an important tool to reduce it. And I like this, what Dr. Chellani was saying, it actually makes every baby have her own individualized, empowered nurse when the mother is there with the baby. And we all struggle in LMICs to have a 1:1 ratio, or even sometimes it is as much as 1:5, 1:6. And having the mother there, or a surrogate whose only interest is the baby, would be a tool to improve many outcomes, not only just infection.
Thank you, Suman. I have an audience question coming in that's related to that. From Betsabe Butran, they ask, could you describe how the fantastic support continues after discharge? So we know that there's this well of excitement when there's a newborn, and you're getting all of that community support. How do we transition that into the home atmosphere?
Yeah. So maybe I should answer that. Like has been said, particularly in Africa, there's a social network, of support. It is routine that when a woman has a baby, people come around to assist and everything. And so, this is even more a positive way. Once they start in the hospital, once a grandmother can assist the mother in putting the baby as a surrogate, to the chest, or the father does it, like the man you saw in the video, they had twins. He was so happy to have the 2 babies there. And he would say, the baby is hearing my own heartbeat. I feel as if I'm the pregnant woman, So I believe that because it was started in the hospital, it is easier to continue at home. Because they were supporting her at the hospital, they could also support her at home. So I think it's easier to continue the support when they get home. And remember also that the traditional way of caring for a baby is that in some families, in some parts of Nigeria, the babies will be taken over from the mother, by the grandmother, whereas the mother will be the one to be doing the work, and usually the mother is one that actually needs the support, the rest and everything. Now that the mother can put the baby on her chest or the grandmother can do the same, then, everybody wins. The baby gets the care the baby needs. The mother gets the rest she needs too, because she has a baby on her chest and the family members are all around to also give the support. So I think the support, it's the one they have in the hospital helps them to continue the same thing at home. I know that the Indians will have a different experience as well.
Karen, if I may add, so in our setting in Ghana, I think it's similar in Nigeria as well. Grandmothers, mothers-in-law, they wield a lot of authority when it comes to care of the newborn. I mean, it's their domain. The father is literally pushed to the background. Okay, so it's like what the grandmother says is what goes. So from the very beginning, I think that we need, the trick is to make the grandmothers and the mothers-in-law advocates. They need to buy into the idea. Once you explain it to them and they understand the benefits, what could happen, her daughter-in-law or her daughter has given birth to a premature infant, and we realize that if the baby is placed in skin to skin, it helps with breast milk, baby becomes bigger earlier, and then earlier discharge. Earlier discharge is usually the key. Once a baby is putting on weight at a quicker rate, and you promise them that if a baby puts on weight quickly and everything is fine, they can go home early. You've bought her support. Okay, so if the grandmother or the mother-in-law buys into the concept of the iKMC, I think that it would continue and it would make a huge difference, because once they go home, they control everything. When the mother should breastfeed, when the mother should eat, what the mother should eat, who should get access to the baby, and so on and so forth. So getting the grandmothers, mothers-in-law, and even aunties, and it was even evident in the trial as well. With the surrogates, the bulk of the surrogates, I think the highest number was grandmothers, followed by aunties. Then you have fathers, and then you had a few friends, and so on and so forth. So I think the trick would be getting the support of these authorities, so to speak, from the very beginning, and then it can be sustained. I don't know what the experience is in India. Dr. Chellani Suman.
Yeah, I would just add that one of our audience members is asking exactly that. Marzia Hassanpour from Iran specifically asked how to prepare mother and relatives during emergency delivery. And as you mentioned, Naana, that it's so important to get people on board who wield that power in the family, like mothers-in-law, like grandmothers. So if anyone else wants to add on how we prepare the relatives, particularly during an emergency delivery for immediate kangaroo mother care.
Yeah, I want to say that, because it was a study, we prepared them antenatally. You go to the clinics to get the pregnant women to know that in case you are going to have a baby who is born before term, these are the kind of things that are available for the babies, and also we also show them women who are practicing iKMC during the period where the mothers are taking round the wards, when they come to book for antenatal clinic. And so they have an idea. And also, we have video that's stationed in the antenatal clinic, that are playing playing iKMC films so that they can see these things and they can ask questions. And usually when they then come, to deliver, then it's easier because you can easily take permission from them, consent to take part in this. Now it's not a policy. It's not a policy of good practice. So it's just for each country to adapt it, and there will be no need for consent for that again. It was a study originally. And after this too, during the period, particularly those who come as emergencies, those are the ones that maybe I've never heard about kangaroo mother care and immediate KMC. Those are the ones that you need to sit down with and talk. And usually because it's an emergency, you give them an abbreviated form of the consent so that they can understand what they want to put, what they are about to go in for, and the impacts of it. And I would say that even those who come as emergencies in our hospital, they were just, they wanted just a care, just any care that will make baby survive. They were just willing to do it. So they are the ones that actually tend to give in consent easily, because they just want any care that will just do it. As Nana said, these are also the ones that may not bring in a surrogate at that time, because it's an emergency. They didn't know there would be need for surrogate. There's some secrecy about delivery in Nigeria. You don't want everybody to know we are going to deliver until you have delivered. So they may not come with another family member, and the husband comes in, he has to be running around and to get those stuff. How do we overcome this? What to do for such families is to have some backup stuff, for emergency care for such mothers, so that when they come and they have to deliver by cesarean section or by SVD, you can easily help them, by providing the things they need, so that the father can be, comfortable enough and assist, or the person that comes with them can be the surrogate at that time.
Thank you. And I have a few questions about the mechanics of iKMC from our audience. So Ricky Pebriancia from Indonesia says, is there a minimum birth weight to perform early initiation of breastfeeding? And Fatima Naseri Zaka asks, how long during the day can a mother do this, can maintain the iKMC? Harish, you're nodding. Do you want to take that question?
Yeah. So for the study, we started the KMC, immediate KMC means starting within 2 hours and aiming for 20 hours a day. So, but what we find that most of these babies in the bracket of 1 to 1.8 kg, or they are sick. So they might be requiring some time, for putting an intravenous access, or for the examination, or doing some intervention or procedure on that. It is only for that period these babies were not given the kangaroo mother care, either with the mother or the surrogate. So even in the study, what we found, we could give these 17 hours on an average during the acute intervention, acute phase. Later on, of course, once these babies, they became stable, they were given 19 to 20 hours. And initially, the first few hours, maybe first 10 or 12 hours, these till the mother is ready to come to this MNCU, the surrogate they provided. But later on, the mothers, they continued to provide. And that's why these mother newborn care unit has got the provision of both mother as well as surrogate, so that the time when the mother is not available, and it is a support to her also. And I just want to add to this, garment is such that it is not that mother has to lie down. It is such that mother can walk also, holding the baby. And it is such a unique that even there is no flexion of the neck, and stability is very good, and mother can walk in the unit. So it's that kind of the garment which has been there in use.
Perfect. And on that, since there is that mobility for mothers, sure, Suman, one quick.
I just wanted to add, because as I have been working with KMC for 2 decades, the kind of duration of KMC I saw in the iKMC I have not seen. I have not been able to achieve the same even in my own unit, 20 hours, 17 hours of KMC. And I think one of the key reasons for the success was this group of personnel who were there, which we call as KMC support team. Now, the job of the KMC support workers was only to help the mother put in KMC and remove KMC and support for breastfeeding. They were not nurses. They were, only meant for this, and they had a big role, because initially, especially when a sick baby on CPAP, you need someone to help them put in KMC. And later on, subsequently, when the mother and the surrogate are confident, they can even do it themselves. So that initial support, every time a baby needs to come out for some reason, and otherwise you'll find them waiting for the nurse to, come and give KMC. So I think having some category of people to support kangaroo mother care and breastfeeding would really help in the long duration of KMC.
There's 2 good questions coming in that I want to throw to to you all. So it's from Adeneke Oluwakemi Oga, and they ask, do the studies claim that iKMC reduces mortality and morbidity in all newborns, regardless of birth weight and gestational age? Harish, do you want to take that?
Yes, in fact, there were two strata, that 1.5 and 1.8 to 1.8 kg. And we found that mortality reduction was there as a whole, both at the 72 hours when we measured and at 28 days of age. And that reduction of the mortality was there. And as we were mentioning, the possible reason were the hypothermia was less, the infection was less, and definitely the exclusive or early breast milk support was there. In fact, in the conventional NICUs, mothers come intermittently and they provide the breast milk. Here, there is an opportunity because both of them are together. So there will be early access to the breast milk and there will be less cross infection. So these were the reasons for the reduction in the mortality in as a whole. Yeah.
And then Adenike, sorry if I'm mispronouncing your name, also had more of a comment on the space challenges. So they write, to establish an MNICU, we'd certainly need space to accommodate the big adult beds in the NICU. It means a lot of NICU wards will have to undergo major structural renovations. And they also add, most third world health facilities may not be able to afford this. So what would you all say to that?
So yes, this is a major challenge. So I would say now the World Health Organization's guidelines are also in place, which were released on 17th of November, that every baby who is below 2,500 gram and who is not critically sick has to be given the kangaroo mother care. Now, I would say any fresh units which we are trying to make now, they must have the mother newborn care unit, or what Suman was saying, family-centered care concept. Because in any case, we have to provide bed to the mother. So it is a reorganization of the structure. Ultimately, for the whole hospital setup, mother-child center, if we see, the space would not be much. It is only reorganization of the structure. So the new units will definitely be like that. In the places where the provision for bed to be there in the NICUs, yes, it is very good. Otherwise, at least I would say, start keeping the mother and the baby together as long as possible till one finds the space. And I find wherever there is a will, there is a way, and one can find out the way to keep the both mother and baby together.
So the immediate goal is to unite the mother and child, even if we don't have enough space for the MNICU beds at the moment. Just the critical care of that immediate iKMC is what's really important. Well, thank you all so much for your expertise. I do want to wrap up today's panel, and thank you so much to all of our audience members for sending in such great questions. There are more questions that we weren't able to get to, so we will be posting resources to answer more of your questions about iKMC. And I wanted to give a very big thanks to all of our distinguished panelists, Professor Adejuyigbe, Dr. Harish Chellani, Dr. Naana Brobby, and Dr. Suman Rao. And of course, for Dr. Jana Patterson as well. Thank you for sharing your insight this past hour. Thanks to our audience for your lively participation. Here on the screen, you can see our landing page. So you can pick up your phones and take a picture of that QR code. It'll take you directly to this website that you see on screen, or take a screenshot of it. So you'll be able to stream today's show, and you'll be able to catch our future programming as well. We have a survey for you, and we will have more episodes in this series. So mark your calendars for our next session in January. And a homework assignment for all of our participants is to take what you learned today and speak to someone you work with about iKMC and share some of the knowledge that you've acquired on immediate kangaroo mother care. So once again, I'm Shireen Khan. Thank you so much for your time this morning. Signing off from Los Angeles. Take care, everyone, and I'll see you for part 2 of our series on iKMC.
Thank you, Shireen. Bye-bye.
Thanks, everyone. Bye.